شكرا دكتور احمد على this nice presentation. Now with Dr. Mohammed Soliman, we speak about lateral ankle instability, a look beyond simple ankle sprain. دكتور محمد.
السلام عليكم. بسم الله الرحمن الرحيم. اللهم اشرح لي صدري ويسر لي امري واحلل عقدة من لساني يفقهوا قولي. Good evening, our esteemed guests. Our talk today about lateral ankle instability, a look beyond simple ankle sprain. Ankle sprains are one of the most common injury in sports. Roughly one ankle sprain per 10,000 person per day occurs worldwide. There are three types: high ankle sprain, which is syndesmotic injury, low ankle sprain, and there are two types of low ankle sprains: medial, which is quite rare in isolated form, and lateral ankle sprain, which is the big chunk and the main topic of our talk today. I'm not gonna dive deep in anatomical details, just a quick reminder. The lateral ligamentous complex consists of three ligaments: anterior talofibular, calcaneofibular, and posterior talofibular. The anterior talofibular is the primary static stabilizer for anterior translation of the talus and inversion of the ankle in plantar flexion, while the calcaneofibular is the primary static stabilizer to inversion in neutral and dorsiflexed ankle. Posterior talofibular prevents posterior translation of the talus. The clinical scenario, which is the common presentation: a young male during sports sustaining pure inversion or inversion on plantar flexed foot. The patient suffers popping or tearing sensation in the ankle, swelling, pain, edema, tenderness over the affected ligaments. Plain radiographs are requested according to Ottawa ankle rules. MRI is not routinely required in acute setting. Conservative treatment is the mainstay for almost all ankle sprains acutely. RICE protocol, medications, immobilization classically was prolonged for up to 6 weeks, and this has fallen out of fashion. Now it's just for 1 to maximum 2 weeks, followed by physiotherapy, which is the cornerstone of the rehabilitation after acute sprain. Physiotherapy should be directed for peroneal muscle strengthening, proprioceptive and neuromuscular training, range of motion exercise. Outcomes are good to excellent for about 90% of the cases. But what about the remaining 10%? They continue to experience sensation of giving way, persistent pain, recurrent ankle sprain, and this is what we call chronic lateral ankle instability. And we should recognize two types of lateral ankle instability. There is functional and mechanical. Functional is mere sensation of giving way without structural deficit, while mechanical instability is an objective sensation of giving way due to the presence of actual mechanical deficit. How can we appreciate this mechanical deficit? After fulfilling the routine ankle and foot examination, there are two tests that I would like to highlight and should be performed. Anterior drawer test, resembling that of the knee. By one hand, you stabilize the distal tibia, and by the other hand, grabbing the heel and trying to dislodge the ankle forward. There is a possible suction sign that might be present on the lateral side. Another test is varus stress test. Inversion stress in neutral position, positive in calcaneofibular ligament. Of course, should be compared with the contralateral side. Plain radiographs, standard views, and stress views. Stress views are the radiological application of the stress test that I would just administer. Anterior drawer test with anterior dislodgement of the talus for more than 10 millimeters is considered positive, while the talar tilt of more than 15 degrees is considered positive. هنقدر نشغل الفيديو؟ يا رب يشتغل. This is under image intensifier in the OR. Sorry about the bad quality. You can notice the anterior displacement of the talus, anterior displacement. And this is the talar tilt. Ultrasound is arguably as efficient as MRI in demonstrating ligamentous injury, provided that it is done by a competent sonorist. It is operator dependent after all. MRI is very important for appreciating the ligamentous injury and other associated injuries that might be present, like OCDs, peroneal tendon injuries, loose bodies, and bony contusions. But in spite of the tremendous amount of information that the MRI brings, it does not substitute the necessity for clinical examination and stress radiographs, stress plane X-rays. Here comes the juicy part. Surgical options. There is anatomical and non-anatomical. Non-anatomical repair, tenodesis, like Christmas-Snook, Watson-Jones, and Evans procedure. These were very common in the past, but have fallen out of fashion in favor of anatomical repair, which is now the gold standard. Rostrum procedure with its variable modifications. The rostrum procedure is a direct ligament imbrication and repair in lateral decubitus, spinal or regional anesthesia. The approach is J-shaped or utility approach. Incision begins at the level of the plafond and extended distally and posteriorly to the level of the peroneal tendons. The superficial peroneal nerve is protected, dividing the peroneus tertius fascia longitudinally and retracting it to expose the joint capsule. Remnants of the ATFL embedded within the capsule. At the distal part of the attachment of the anterior inferior tibiofibular. Like that is demonstrated in the picture, imbrication of the ATFL. This is the original rostrum procedure. Calcaneofibular ligament can be administered also. The peroneal sheath is opened and the peroneal tendons are retracted and the CFL is examined. There are various modifications and alterations in the rostrum procedure. Most commonly, the gold modification, fibular periosteal flap, augmentation, suture tape augmentation, and arthroscopic rostrum. The principle of the rostrum gold procedure or the gold modification of rostrum procedure is the use of the inferior extensor retinaculum to reinforce the repair. Post-operative care, non-weight bearing for 2 weeks, then progressive weight bearing with walking boots. Results are 85 to 95 success rates. So take-home message, for acute sprain, short immobilization, then physiotherapy. The surgical intervention in acute sprain is only recommended for the high-end athletes. Well, not every day Mo Salah comes waddling around in your clinic anyway. But for chronic ankle instability, there are two types: functional physiotherapy and mechanical anatomical repair. شكرا.